So the case history to the 14 years old Hindu female, a resident of Balasore, presented with the chief complaints of multiple swelling over upper and lower limbs since 6 years of age, easy fatigability for last 3 years, and shortness of breath for last 1 year. These are the chief complaints. The history of presenting illness. Since the age of 6 years, the patient's mother first noticed few raised swellings over elbows that gradually increased in size. Similar skin lesions also developed over fingers, buttocks, knees, and around both eyes. The lesions were skin colored, painless, non-itchy, without any loss of sensation.
Excuse me, I cannot see anything on my screen. Is everybody else seeing this presentation?
Yeah, I am able to see. Dr. Justin, I am able to see.
Yeah, roughly here, I am able to see.
Everybody is seeing perhaps, I don't know what's happening.
Praful, can you see?
Yes, I can see.
I can also see it very clearly.
Yeah, clearly. Maybe some local issues, sir. Just try to see whether you can go off and come.
Should I continue?
Yeah, I think you can. Admin, you can put sir in the waiting room and then call back. Sometimes the video comes back if you do that. Yes, doctor, you can present your case.
About 3 years back, she developed easy fatigability, which was insidious in onset and remained at the same level. She felt fatigued on cycling and was unable to run and play with peers. She was comfortable at rest. Just class 2 symptoms. She also complains of shortness of breath during cycling and playing outdoors from last 1 year. It was insidious in onset and non-progressive. The symptom subsided on taking rest for few minutes. The symptoms were class 2. There was no associated orthopnea, PND, fever, cough, expectoration, hemoptysis, or pedal edema. For the above complaints, she went to local practitioner who detected some form of cardiac illness and referred her to SCB Medical College for further evaluation. There was no history of bluish discoloration of skin, chest pain, syncope, or palpitation. The past history, there is no history of fever associated with joint pain in childhood or any symptoms suggestive of rheumatic fever. No history of recurrent respiratory tract infection. No history of cyanotic spells and and squatting episodes. No history of tuberculosis, bronchial asthma, diabetes mellitus, hypertension, CAD, or stroke. The birth history and the developmental history. She was born from a non-consanguineous marriage by normal vaginal delivery at full term. All the developmental milestones were at par with peers. Personal history. She belongs to lower socioeconomic strata and presently studying in 9th standard. She had normal bladder and bowel habits, normal appetite, and no addiction. The family history. The patient has an elder sister and a brother. The sister is having similar skin lesions over upper and lower limbs. Her mother has prominent xanthelasma. Her mother has 2 brothers who had prominent xanthelasmas. One of them died prematurely at 46 years of age, most likely due to premature CAD. No history of any significant cardiac illness in other family members. The menstrual history, she attended menarche 2 years ago.
Yeah, I think I've got it now.
Having regular cycle.
Okay, thank you.
She is on tablet atorvastatin 40 mg once daily. Summary of the history. A 14-year-old female coming from low socioeconomic status presented with swellings on upper limbs, progressively involving the lower limbs since 6 years of age, non-progressive, easy fatigability, that is class 2 for last 3 years, and shortness of breath on exertion, that is class 2, for last 1 year. Significant family history includes similar skin lesions in elder sibling with xanthelasma in mother, who is a first degree relative, and a history of premature death in one maternal uncle, who is a second degree relative.
What is your differential diagnosis?
Swellings, no? I guess that's lemons or what are these?
So mainly for the upper limbs, the lower limbs.
Can you mute some of the places?
Asthma was there.
Noises here. Can you help?
So we were thinking of some lipid storage disorder, some hyperlipidemic states. Most probably some familial hypercholesterolemia, which can present like this, or apart from that, mucopolysaccharidosis as a lysosomal storage disorder can also present like this, and cytosterolemia can also present like this with similar skin lesions.
Yes, skin lesions or subcutaneous nodules?
No, so that was skin lesions, sir, actually. That was nodular in shape and well circumscribed lesions were there.
The skin is not pinchable over the swelling or nodule.
No, sir, not pinchable.
Based on this, what is your differential diagnosis?
So mainly categorized into two, sir. One is lipid storage disorder, another is lysosomal storage disorder. In the lipid storage disorder, sir, mainly familial hypercholesterolemia and cytosterolemia.
This is your first differential diagnosis. I can see from the summary that this is going to be the first differential diagnosis.
Sir.
Okay. Then explain why there is an easy fatigability in class 2 from last 3 years and shortness of breath class 2 from last 1 year.
Sir, due to some, so we were suspecting some valvular involvement, sir. Most probably a fatigability lesion comes from a regurgitant thing. So most probably,
So your first differential diagnosis, any valvular lesion in this patient.
valvular lesion associated.
And basically a regurgitant lesion. Which regurgitant lesion?
Yes, sir. Regurgitant.
Is fatigability is a main complaint of which regurgitant lesion?
Mitral regurgitation, sir.
Mitral regurgitation. So on this basis, first year is a wall involvement.
Wall movement, sir.
Okay.
Sir.
So there is nothing specifically pointing that she has a heart disease. Somebody coming with a shortness of breath and fatigability, do you think in terms of heart disease straight away?
No, sir. Not that way, sir. But that was the only second complaint which the patient complained, sir, apart from the skin lesions.
So what will be the other possibility? Is he fatigability and shortness of breath? He is having anemia because some disorder and any chronic disease may lead to anemia.
Yes, sir. Hello. Actually, sir, the patient is complaining of skin lesions since the age of 6 years and fatigability since the last 3 years and shortness of breath since last 1 year. So it might be possible if there is some extra cardiac disease may be possible. Female is 16 years of age and she achieved menarche at 14 years. So might be simultaneous skin lesion and severe anemia may be there, or hypothyroidism may be there, or maybe sir cardiac involvement like in the form of valvular disease, or maybe sir
Only valvular you will keep. Only valvular you will keep.
valvulus or myocardium involvement may be there, like sir idiopathic.
Second familial hypercholesteremia may have accelerated atherosclerotic disease also. So, have you kept the possibility of premature coronary artery disease in this?
Yes, sir. Coronary artery disease we kept, sir. Associated premature coronary artery disease can be a presentation for familial hypercholesterolemia.
Then what will be the presenting complaint? If suppose it is a premature coronary artery disease, so what might be the presenting complaint?
She may complain of the chest pain on exertion and shortness of breath, sir, due to myocardium involvement.
So you are sure in familial hypercholesteremia at this young age, this chest pain will be the major complaint to rule out coronary artery disease?
Yes, sir. It may be due to the epicardial coronary artery involvement or due to microvascular involvement. So it may be, or some due to some lipid storage disorder, and due to some lysosomal storage disorder, it can be due to the restrictive cardiomyopathy or.
So this will be your other differential diagnosis.
Yes, sir.
Come to examination, then it will be easy to differentiate it. Okay.
Coming on to general examination, the patient was conscious, alert, cooperative, oriented to time, place, and person. No pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy, or thyromegaly. Height was 1.46 meters. Weight was 42 kg. BMI 19.7 kilogram per meter square, and temperature of 98.2 degree Fahrenheit. Pulse was 88 per minute, regular, normal volume, normal in character, no radial or radiofemoral delays. All peripheral pulses were well felt. Condition of the arterial wall was just palpable. Blood pressure was 110 by 70 millimeter of mercury in right upper limb and 120 by 76 millimeter of mercury in right lower limb.
Just comment upon your blood pressure if your measurement is correct or not. What is the fallacies in your blood pressure?
So in sitting position we have to know.
There are two different, 110 by 70 and 120 by 76.
Sir.
So what happened to diastolic pressure in both the arms?
Sir, in both the arms we didn't mention, sir. Actually, we should have mentioned.
So if the diastolic pressure differs in upper and lower limb?
Sir, for a possibility of aortic regurgitation.
So does it say there's a difference in diastolic pressure or there's a difference in systolic pressure?
Systolic, sir. Systolic.
So usually the diastolic pressure is same.
Same. Sir.
So we never mention diastolic pressure in lower limb because the cuff size may be different.
Sir.
The rest everything is normal.
Sir. Sir.
Okay, go ahead.
In the skin examination, sir, the upper limbs were multiple soft to firm, mobile, well circumscribed, smooth surface, non-tender skin-colored nodular lesions over proximal, interphalangeal, distal interphalangeal, and metacarpophalangeal joints of both hands. Multiple similar nodular lesions over bilateral elbow joints were also present. Few skin-colored papules over dorsum of hands are present along the tendons. In the lower limbs, multiple raised, well circumscribed, smooth surface, non-tender plaques, nodules, and papules over bilateral knee joints and buttocks.
What they are called as?
Do we have any picture of those nodules?
Yes, sir, sure, sir. We have. Sir. So this was on the elbows, sir, bilateral elbow. This is showing suggestive of tuberous xanthoma, sir. On the joints, it is present on the joints. This was on the knee joints, sir. Multiple papular lesion, raised lesions was there, sir. Multiple raised lesions were there, three to four. And in this is on the dorsum of the hand, sir. Along the tendons, it is there. This one was the largest one. This is also suggestive of tendon xanthoma. And in the eye, sir, on the both medial and lateral canthus, there were prominent xanthelasmas.
What was inside the eye?
No evidence of, sir, any arcus cornealis was not there, sir. We searched for that.
Still inside? Fundus?
No, fine.
You didn't see it.
So there was no evidence of lipemia retinalis was not there.
You looked for it. Good.
Yes, sir.
Good.
Sir, this was the skin, these were the lesions, sir. And once a family history was there, sir. This was of the elder sister, sir. Elder sister had similar lesions on the elbow, and these were the lesions, similar lesions on the proximal and distal interphalangeal joints. And this was the knee lesion, sir. This was also suggestive of xanthoma, sir, on bilateral. And this is the xanthelasma, prominent xanthelasma. She was the elder sister, sir. So, now, sir, examination of cardiovascular system. The chest inspection, the chest was bilaterally symmetrical, Apex beat appears to be in the left sixth intercostal space, 2 centimeter lateral to the mid-clavicular line. No precordial bulge, scar, or venous prominences. On palpation, apex is confirmed to be in left sixth intercostal space, 2 centimeter lateral to the mid-clavicular line. It was forceful and ill-sustained. No parasternal heave and no palpable heart sounds. On percussion, the left second intercostal space is resonant on percussion, and left heart border corresponds to apex, and right heart border is substernal. On auscultation, the first heart sound was soft. The second heart sound had a soft aortic component, a normal pulmonary component with wide variable split. The third heart sound was present. The LVS3 was heard at apex. Fourth heart sound was absent. Coming on to murmurs, there was a grade 3 high pitch, soft blowing, pansystolic murmur, best heard at apex and radiating to axilla. An early peaking, harsh, medium pitched ejection systolic murmur of grade 3 covering less than 50% of systole, heard at right second intercostal space and radiating to both carotids. A high pitch, soft blowing early diastolic murmur covering less than 50% of diastole is heard at left third intercostal space that doesn't increase with inspiration. A rough rumbling, low pitched mid diastolic murmur best heard at apex in left lateral position, and no other extra sound was audible. This was the examination of other systems. The respiratory system, there was a bilateral vesicular breath sound heard, no added sounds. On abdominal examination, no organomegaly, no free fluids, gastric tympani present on the left side, liver dullness starts from right fifth intercostal space along mid-clavicular line with a span of 10 centimeters. And in central nervous system examination was within normal limits. So the summary of the clinical findings: 14-year female with normal hemodynamic status with evidence of tuberous and tendinous xanthomas over small joints of both hands, bilateral elbows, bilateral knees, dorsum of hands, along the tendons, buttocks, and xanthalizing.
What was the length of the mid-diastolic murmur?
It was less than 50% of systoles.
Short murmur. Was there
Short
a pre-systolic?
It was a short murmur, sir.
Was there a pre-systolic murmur?
No, sir, no pre-systolic murmur.
You need to mention that. Go ahead.
The clinical finding summary regarding the murmur: there is presence of severe murmur, MR, severe mitral regurgitation as evidenced by cardiomegaly, soft first heart sound, wide and variable splitting of second heart sound, third heart sound at apex, a grade 3 high pitched soft blowing pansystolic murmur at apex that was radiating to axilla, and a rough rumbling short mid diastolic murmur best heard at apex in the left lateral position. There is presence of moderate AS and mild AR as evidenced by soft aortic component of second heart sound, and early peaking harsh medium pitched ejection systolic murmur of grade 3 at right second intercostal space radiating to both carotids. A soft blowing early diastolic murmur covering less than 50% of diastole at left third intercostal space.
Do you have any evidence in favor of moderate aortic stenosis apart from what you have shown here?
So the murmur was actually.
You have mentioned it is an early peaking murmur, na? Early peaking murmur, then why you want to keep a moderate AS as a diagnosis?
So the aortic component was soft, sir. So we thought in mild aortic stenosis, the aortic component will be preserved, sir, comparatively.
No, why there is a soft aortic component? What is the pathophysiology behind that?
So there is involvement of the margins of the aortic valve, sir. That leads
it becomes rigid, simple. Either it is calcific.
Yes, sir.
And most probably the cause of aortic involvement is extensive fibrosis in this patient.
It doesn't have to have a stenosis to be soft in this scenario. What happens to the A2 in aortic stenosis moderate? It closes early or closes late?
It closes late, sir. Late closes.
Severe MR?
In the MR, sir, the aortic valve is closed early, sir.
Early. So, despite your presence of moderate aortic stenosis, it is still closing early.
Sir.
So, you don't really have to bring in a moderate aortic stenosis here without sufficient clinical evidence for it.
Actually, sir, most of the finding of AS is masked by the proximal region like MR. That may be the reason, sir, we are not getting the all finding of moderate AS, severe AS.
Then it is better to say it's a mild AS. With your finding, if you say it is a mild AS, what is the harm? Because you can't show moderate AS, that's why you are bringing the moderate AS in this scenario.
Echo has moderate AS probably.
Actually, that is why I said either let it be either mild or severe. So you moment to bring in moderate and mild to moderate is we can judge nothing. So let it be mild AS, if you want to say that.
Okay. Is it clinically, sir, we can tell mild AS?
Why not? Because of the A2 component that you have already explained.
Yes, sir.
That A2 could be solved because of the fibrosis of the aortic valve. Does not need to essentially be because of severity of AS.
Yes, sir.
And did you really hear the mid-diastolic murmur to be rough and rumbling? Generally, the flow murmurs are not that rough. Like you
Yeah,
see.
but the moment you say it is rough and lumbling, it means that the mitral stenosis is organic.
Yeah.
And it's basically always safe to say that the patient has an organic MS in a multivalvular situation. I mean, it is rough and rumbling, and the only thing is that it is short, and there's no pre-systolic component.
Systolic accentuation and opening snap was not there, sir, at all.
You need to mention that. You can say they have a short mid-diastolic murmur with a pre-systolic component, and put inside by a third heart sound. So you're sort of telling us that this is a flow murmur. But when you say rumbling, it sort of brings an organicity to the.
और क्या खबर है?
Yeah. So basically, this is for your examination purposes.
आंटी की तबीयत
That
कैसी है?
whenever you want to put this murmur as a flow murmur, it is better not to call it rough and rumbling. Just say it is a soft, short mid-diastolic murmur at the apex, which will mean it is a flow murmur because of a severe MR.
तुम्हारे
or an
वहाँ
AR.
का काम कैसा चल रहा है?
Sir.
अच्छा बहुत बढ़िया।
Okay, so anything else, Dr. Kendar, you want to ask anything?
No, it's fine. So far, everything is going okay.
Because I'm sure
Typical
it doesn't have
exam
any.
case. What I want to say is that this is a once in a blue moon that you get to see a familial hypercholesterolemia.
Yeah, that's the question that I want to ask. I mean, very rare that you get to see this.
More a publication.
Cardiology.
रात में
More a
Are
publication.
the two interrelated? Is there any correlation between this valvular heart disease and this familial dyslipidemia xanthoma situation?
Yes, sir. Actually, sir, in familial hypercholesterolemia, sir, maximum number of times, the most number of cases that have been reported, there is the involvement of.
Aortic valve.
Yes, it is mainly involving the aortic valve and most probably the root thing it is involving, sir.
Yeah, but then I'm talking about mitral regurgitation.
Yes, sir, that is very rare, sir. A
Very
hemodynamic
rare to have mitral
regurgitation is very rare. We searched literatures also, sir. It was showing only echocardiographically detected, mild MR they have shown, sir. And by maximum 1 or 2 cases they have reported with a moderate MR. But a severe MR presenting in this way is very sir, typical, or atypical. Sir.
So what is the morphology? What is the morphology of the mitral valve?
So you are trying to say there is a rheumatic heart disease with this patient.
Yeah, it could be rheumatic.
Rough and rumbling. In our country, rheumatic is quite possible, no?
That's why it belongs to. What is the morphology on echo?
Sir, I'll show, sir. I'll show echo.
ECG. Then let's look at the ECG. Okay.
Sir. So this was an ECG, sir, a 12 lead ECG with a normal sinus rhythm. An axis of 60 degree was there, sir. QRS rate,
Mention QRS axis. That makes it much
the QRS axis of 60 degrees, sir, with a rate of 100 per minute with signs of LVH according to Sokolov law, sir. V1S plus V5R of 46 millimeter was there. Post probably due to volume overload with a prominent Q wave in V5, V6 was there. And there was no evidence of left atrial or right atrial enlargement or any other conduction abnormality.
How will you define prominent Q wave?
Sir, prominent Q wave, sir, in V5, V6 will be, sir, around 30 milliseconds, sir, with a depth of 1 mm.
At least one square, one by one square. Okay.
Yes, sir.
We are not able to see, okay, we believe it.
Sir.
We are not able to see this.
Sir, the lower one is, sir, half standard, sir. The lower ECG is half standard, sir.
Okay.
You can see in that. And, sir. Yes.
Go ahead, show the echo.
So this was the echo, sir. This was the parasternal long axis view, sir. It is showing, sir, left atrial enlargement, sir. Along with left ventricle is also enlarged. And we can see, sir, the thickened aortic valve, sir. The thickened aortic valve is there. Along with that, it is also involving the mitral valve, sir. Base of the mitral valve, base of the anterior mitral leaflet, and as well as the posterior mitral leaflet. And sir, we can see, sir, that the wall, the aortic wall, is thickened, and it is continuing up to the base of the mitral wall. So the pathology, sir, that is continuing along with the aortic wall into the mitral leaflet.
Actually, if you know the diagnosis, then you start imagining this thickness. Otherwise, I would really not. I would really not actually pick up this kind of thickening on a routine echo. Now, since we have that diagnosis in mind, then we start looking at the aortic root thickness and going right up to the mitral valve. But if you have a first look at it without knowing the etiology, you're likely to sort of miss it.
No problem.
Yadav, क्या कहते हैं आप?
बिल्कुल है. अगर if it is measured, I don't think it is more than 3 millimeter mitral wall. It has been presumed.
No,
If there is no cordy rupture, they have seen that there is not a cordy rupture.
Yes, sir.
Because if you see the tip of the mitral wall in this view only, you need to see more views.
One other thing is the base of the leaflet is because otherwise we'll call this mitral aortic discontinuity, isn't it?
Yeah, that's right. I mean, this looks more like that.
You understand what I'm trying to say?
That is how we look at the posterior discontinuity and double outlets.
Yes.
When you see that there is a thickening right up to the mitral valve.
Yeah.
It is something sitting between the mitral valve and the aortic root.
Absolutely. It is pretty much there, what he's saying.
Yeah, that's what I said. I mean, when you look at it from that point of view, you start seeing it.
Yeah.
Next.
Okay, so far, so good.
Next, doctor.
Next.
So this was the color Doppler, sir. This was suggestive of severe MR, sir. Eccentric jet that was posterior directed. It was a severe MR, sir. With a jet area, sir, in 2 dimension we measured, sir. It was around 10.3, sir. With an LA area of 16.2. That was around 60%.
Next. Yeah, go ahead, doctor.
So this was the parasternal short axis view, sir, at the aortic level, sir. We can, at the aortic zoom view, sir, this was showing, sir, a heavy calcification over this right coronary cusp. Sir. and commissures are, sir, comparatively free, sir. They are opening up. So that is also going against the rheumatic etiology.
Absolutely.
If the commissures are open, sir.
Okay.
And the body of the right coronary cusp is mostly involved, sir.
The pulmonary valve is involved or what?
Pulmonary valve was not involved, sir. It was thick,
Here
sir.
it looks like,
thickened actually.
here it looks like,
Yeah, it looks thickened.
Yeah, if you call aortic valve involved, you have to call pulmonary valve also.
see that?
Because
I think it is involved.
or
Pulmonary valve is thickened.
your settings are so high, so different that it makes look everything look involved.
It was a zoomed image actually, sir.
Seriously,
Another 5 minutes.
seriously, in fact, here the base of the pulmonary valve is not. It's more the body and the tips, right?
It's more
yeah.
involved than the
Base is nice
Another
and
5 minutes, please.
yeah,
okay. Next.
So this was the
AR.
parasternal long axis, sir, showing the aortic regurgitations. This was probably mild, sir. Jet area by LVAP.
Okay, next.
Next.
So this was for the, sir, aortic stenosis, sir. The gradient was coming almost severe, sir. The Vmax was around 3.88.
Going up to 4 meters. Yeah, okay. Next.
So was our
There is
estimation of the
ALVH. There is ALVH. So aortic stenosis is severe, right?
so where we sort of wrong in assessing the murmur, it probably did peak late. You said it was short and not peaking late, so probably the murmur was long and peaking late.
There is LV dysfunction and there is LVH. Okay.
Actually, we have already said earlier, so due to the proximal lesion like MR, some of the finding of the AS we have not sure.
Exactly.
Okay.
Next.
So, but MS is not there, no? That's why.
No, sir.
The easy fatigability is because of that. Is that right?
So mitral regurgitation. Mitral.
Okay. Are we done? Okay. Describe that M mode of the mitral valve for old timers' sake.
Yeah. No.
Describe
Tell
this.
us about the M line.
No, yeah, but hang on there. Tell us about what do you see on the mitral valve.
In the most we are seeing the thickening of the anterior and posterior side both.
Thickening? No.
Anything else
Across the
which
tip.
can make it look thick? Some kind of vibration, some kinds of.
You see the flutter, what Dr. Rakesh Yadav was telling you, right? So that is because of what? What is that flutter on both AML as well
AR jet
as well as PML?
Yes, sir.
Yes.
So the
Because
AR
jet.
this is a classical M line sign of AR.
yes, sir.
Yes. What about the EPSS?
Yes, sir. EPSS. Yes, sir. EPSS was more than 5 mm, sir. So some
It has to
dysfunction.
be more than 8 to call it LV dysfunction. I think it is more than 8 here. What is the EP like?
It is more than 8.
Also, so septal movement is somewhat less flattened.
Flattened. Okay. Go ahead. Then now show us the angiography.
Sir, angiography was done, sir. This is the areocranial view, sir.
So there is some ostial left main also.
Yes, sir. Sir, LAD was diffusely diseased, sir, actually, sir. From the D1 to the D2 or D3, sir.
What Dr. Kelkar is saying is an osteal disease of the left main also.
Is there or there isn't? This is because of the radial angio. No, this is not radial. This is proper
It's a femoral one, sir.
How
The ostial lesion is not for, sir, because reflux is there. And
Good to say.
Catheter has not gone in at all, right?
yes, sir.
Whatever you see compared to the shaft of this thing, whether there is, you should almost always try to look for it, right?
Which is the best view for left main ostia?
So this one is.
No. Iliocranial.
Iliocranial.
But something is preventing you from entering the left main inside.
Because the root is big. The root is small and the catheter is an adult catheter. So
it's a small age, small height child, sir.
I know. It's difficult always. LCX osteal is minor. But that other first PA cranial shot was showing it to be significant here. See that? There is significant osteal CX also, right? Or no?
Yeah, not two of them. Yeah,
This view, it looks significant to me.
In this view, sir, it was.
Yeah, this view, it is not really profiling well enough. Next.
Too much of radiation is being given.
So for the final diagnosis, sir, we kept as a case of homozygous familial hypercholesterolemia with a valvular heart disease, equally severe MR, moderate AS, a mild AR with moderate pH, with mild LV systolic dysfunction, with evidence of coronary artery disease.
Okay. So what gene studies have you done?
So we didn't did the genetic analysis.
You want to publish this case, right? And you haven't done the genetic analysis.
So it is very costly, sir. The costs are not done at
Costly means you can get whatever kind of donations. During COVID time, we get so much donations. तो ये करा के publish कराना है तो gene study कराओ ना. कर दिया publish already.
No, not published, sir. Not published, sir. Actually, sir,
16 points कराना है वो ठीक है.
So this is the score of the Dutch Rapid Clinical Network criteria, sir. We are getting a score around 16. That is a clear-cut definite diagnosis of the familial hypercholesterolemia. Even without the SCB mutation, we are getting clear diagnosis of familial hypercholesterolemia.
Yeah, that history was good enough, no? To say it is familial hypercholesterolemia.
Also, sir, according to the European Atherosclerotic Society guidelines, we are getting the diagnosis of homozygous familial hypercholesterolemia.
It has to be homozygous. That's what I'm telling you.
Patient has LDL level of more than 500, and also there is tendon xanthoma present from the age of before the age of 10 years. So these two criteria are satisfying the criteria for homozygous familial hypercholesterolemia.
Is it? More often, this presentation is in heterozygous stuff. Because all couples also have, sisters also have. You don't get so many people involved in the homozygous stuff. And tendon xanthomas are very common in heterozygous as well.
So, but sir,
Parents are heterozygous, is it? Or what is it?
Sir, homozygous, sir, because the tendon xanthomas probably appearing before 10 years of age. That is more common with homozygous and a LDL level of greater than 500, sir. 500.
It's possible both parents are heterozygous and all children are homozygous.
Yes, that means.
Praful, I think time is up.
This is
Yes.
this
What
was
is the role of, one last question. Can
Last
you give
question, yeah.
patient after whatever PCSK9 inhibitors?
Sir.
Is she on?
Yes, sir.
Is she on?
Yes.
No, sir.
Mr. Dr. Mrinal.
Sir, we had talked with the authorities, sir, regarding the cost. We had started only on, sir, atorvastatin maximum dose 80 milligram and ezetimibe, sir.
10 milligram.
PCSK9 we have asked for, sir, but the cost issue was there. So we are awaiting, sir, the funding.
There are registries to help
The association, sir.
Yeah, the registries are there and from them get the gene studies. The PCSK9 walas will only do the gene studies for you. Pay for the studies if you can afford the PCSK9 inhibitors.
Sir.
Yeah.
Okay, sir. Thank
Okay,
you
good
very
case,
much.
good case.
Good case.
Good case, worth publishing.
Yeah.
But if you haven't published it, don't present it.
Sir, thanks. Sir, we are trying, sir, just to.
What do you mean trying?
Sir,
Thanks for showing
Okay.
it to us.
Thank you. Thank you very much.